Beyond treatment factors, we also need to look at host factor. Patient's age is a huge factor that drives this risk, as well as gender to a degree. But we also have emergence of genetic risks now. It's been really, especially emerging in the last decade or so with genomic research taking off, and this data will be very interesting to watch. But we cannot ignore other factors, like external factors like social, environment, socioeconomic, and other factors these people experience and live with, as well as lifestyle factor, which is also interconnected with all the other factors. So again, all this many factors pretty much interplay and result in actual outcome we see in these survivors. So these are some of the list of late effects, and this is not even complete list. As you see, this is pretty broad, list of different organ systems this late effects can affect, and they're pretty consequential when you think about quality of life of the survivors. And I need to mention this very important project, this national childhood cancer survivor study, which was funded, which is still funded by NCI, and continues to accrue people. This initial cohort, which resulted in 20,000 childhood cancer survivors on this registry, this is like relatively historical kind of cohort, patients treated in 70s and up to mid 80s. And many of these treatment techniques and modalities and things have improved and changed quite a bit, but this still gives us pretty realistic picture of what we're dealing with nowadays, because these are people now we are seeing 20-30 years from therapy in our clinics. And this was also established for people who need to be at least 5 years from diagnosis. Again, very important data that resulted in multiple publications and different outcomes people have published and looked at, and this is only just some of the list of outcomes reported from this large cohort, and very robust and excellent data we can always refer to. As we can see, some of this results from these studies have shown pretty significant proportion of survivors, and comparing with siblings, this is always helpful to look at relative risk, because we know that even like general population experiences some of this health problems, but it's very obvious that many problems are more than doubled in frequency, and results in pretty significant limitation of quality of life, and they're all listed here. And again, you can imagine they're pretty important in the survivors. And when you think about this is kind of different form of looking at it, and just overall accumulation of chronic health conditions, and this would be actually relatively broad conditions, but even like high grade, like more severe conditions will be a fairly good number underneath this graph. But this blue graph represents survivors, how this risk accumulates, exceeding 30% or so compared to their siblings. And again, this gap only continues to widen as survivors continue to age. And some other ways of looking at it, relative risk increase, again, compared to siblings, it shows now for high-grade conditions, and again, these are serious conditions, mostly requiring some form of intervention. And we have listed here like things like joint replacements, congestive heart failure, secondary malignancy, this is again very significant increase. Other dysfunction like cognitive, coronary artery disease, all this, different impairments are obviously pretty significant to be aware of. And then other major risk we've already mentioned in the beginning, second malignancy is big driver in how these people continue to live, and even this mortality, like risk from these conditions, is not insignificant. We have some of the most prevalent, second tumor risks like breast cancer in female patients. This is, mostly inexpensive patients receiving chest radiation, like Hodgkin survivors, thyroid cancer, other malignant tumors in different body sites. And again, all of this unfortunately results in pretty poor outcome. And as radiation oncologist, I'm obviously always attentive how radiation treatment is contributing to this risk. And we see significant, contribution as you look at no radiation cohort. These are patients treated with chemotherapy, primarily comparing to radiation. There is significant difference, and as we see, even chemotherapy and other treatments can result in second cancer, but radiation risk, unfortunately, it's pretty obvious, accumulates over years, and unfortunately, it doesn't even plateau. It continues to accumulate as patients live longer and get farther and farther from treatments, and it's really achieves like really significant number when you think about like 30-year risk, accumulating to 25%. Again, this really speaks to importance of lifelong surveillance of these people. So what are the needs for our survivors? It's pretty obvious. I think I've made a strong case that this needs to be lifelong, and the risk of these late effects only continues to accumulate. And I listed only just several kind of common ones we deal with in our clinics, but they definitely have like I said, some of them only continue to accumulate this risk, especially initially high risk people who had to have very intense treatments for cancer. And again, this is pretty widespread problem when you think about like different organs and different specialists. They need to be addressing this the organ dysfunctions, as well as psychosocial issues, which continue to happen as patients and survivors get to adulthood, and actually get even more pronounced, and people experience this problems even more as adults, compared to going through this experience as children. So what we have for these survivors is this excellent evidence-based guidelines, which is created by Children's Oncology Group. This is cooperative group, mostly designing clinical trials and new treatments. But this group, understanding importance of these late effects, embarked on also looking at evidence. And there is task group within Children's Oncology Group that's basically in charge to look at evidence and update this evidence periodically. We used to update every other year. Now, it's every 5 years. That results in major updates and changing guidelines, which are accessible to general public. And again, this will be very good resource to any provider in the community. And it spells out, all the toxicities based on exposures, very comprehensive document. Group is very motivated to make this document more user-friendly. That's one of the missions we've had, some of the latest updates to simplify these guidelines. And beyond guidelines, there are pretty helpful health links, which is available to providers as well as survivors themselves. And again, this document and this resources, our kind of main evidence-based guideline we use in our clinics when we deliver care to the survivors. So why do we need to have long-term follow-up clinics? Again, I've made pretty strong case about this, risks only accumulating, then survivors, needing this kind of monitoring is, like I've said, it's pretty much lifelong. And typically this, monitoring begins at least 2 years from completion of therapy. And at that point, the switch happens from cancer patient to cancer survivor. And it's a positive switch, but again, comes with its own, challenges. And this comprehensive review of health status and, check for specific, treatment-related problems is important. And beyond, that, we very much focus on wellness education and health counseling. So how is this care being delivered? And I already mentioned that we have a Children's Oncology Group, behind this, and many institutions which are linked to Children's Oncology Group across the country have dedicated, their clinics to survivors. And majority of, this pediatric centered, pediatric focused programs are still only able to monitor this childhood cancer survivors up to age 21 or so. This is basically most of the limitations, including our center. I'll tell you a little bit later, but there are only a few exceptions to this, St. Jude's and a couple others who can see people lifelong and invite them back for surveillance and screening. So As I've mentioned, both National Cancer Institute and Institute of Medicine recommend this long-term follow-up, and it's a strong, guideline. And I've already mentioned this like real risk of lost in transition between childhood and adult care. This is again very well known problem, and these barriers continue to exist as people are still working on different care models to improve access and adherence to this. So when we think about why this transition is difficult, there are many factors, and obviously on the survivors side themselves, they're in this very critical period of their lives. They're transitioning to adulthood and gaining some independence, but they are still struggling in understanding, navigating very complex adult healthcare system. And they're not always prepared. Even during treatment, they're nurtured, sheltered by family, by providers. And again, this whole preparedness, how they embark on this big journey like as independent individual, is very complicated for them. And there are only limited programs still available to them to have this direct crossing over like this, creating the transition and that pathway for them to help them. So, and I'm happy that we're one of few ones provide this very specific support. As I mentioned, barriers are multifold, and as I've already pretty much stated, on a on survivors' side, it's pretty challenging phase. They are busy with college and other transitions, and some have disabilities, not helping them to even gain any independence on on their end. And it's a struggle between caregiver and survivor, how we can help them to kind of make this path. And there is definitely lots of data about still lack of self efficiency, navigating health systems, and obviously lack of insurance and other insurance and disability coverage. All of these are huge barriers we cannot ignore. And on the provider side, as I've mentioned, there is definitely a need for more knowledge, and survivor-specific, care knowledge is important for all the providers out there. We, in fact, try to work with, our internal medicine, family practice providers to really, help them to buy into this, really care for survivors, and initially even envision to have more transition phase and hand these survivors to them, eventually. But this is challenging. Again, this is very complex, population, and many times, requires management of complex and multiple issues. And in a usual kind of, primary care or family practice, setting, many times, these centers are not, and clinics are not equipped, with these resources. On top of that, we have this multiple needs, including major psychosocial support and other needs, very hard to meet. But one of the biggest challenge which I want to highlight to this group is complexity of care coordination. You will see that later in Mary's part of this, and again, this is something we cannot underestimate. And the system level problems, which I mentioned to a degree, again, overall access to centers, where they can provide this type of care. As I mentioned, primary care, family care, not, being equipped to provide this specific, very complex type of services, and financial support. We already mentioned, this is huge, headache for all of us, when you think about what these survivors need. Let me switch gears and talk about our center, our program specifically, and let me just mention that we have excellent partner, Children's Healthcare of Atlanta, where this initial survivorship care was established back in 2001, and they're one of the pioneers nationally when it comes to quality of survivorship program, and they follow over 1,500 childhood cancer survivors, age appropriate until they age out to age 21. And they have approximately 1,000 visits annually. Again, very big and robust program. They have basically, I mentioned this policy, unfortunately, which still limits them in providing care beyond 21. And this was one of the main things we've started to recognize and collaborate on. This is a list of their team members, and as you see, they have pretty good, group of providers as well as advanced practice providers, and again, very well established and very well supported program. Like I said, one of the best, when it comes to national recognition. How about our transition model? So this, as I mentioned, was one of the first things we've noticed, that this transition between childhood survivorship to adult survivorship, we did not have initially any system in place, and these survivors were kind of spread out into community. Many went back to their local communities, but overall dropout and attrition of like survivorship type care was very substantial, and this was recognized by Emory and Children's Group early on, and we've started to partner early on, and this 2005 was kind of official birth date, I guess, year of our program, and when we had initial seed grant from Emory Children's, supporting our program, grant to start this as an initiative and pilot program, which luckily only grew since, and we've managed to not only maintain but grow it. And as Mary mentioned, she came on board, and the program only continued to grow as a result of our dedication. We see approximately 80 to 90 survivors transition from AFLAC, most of whom end up in our care, and as you see, like 80 to 90%, while some of them remaining, I guess, smaller group, care outside Emory, or they do some transfer to outside systems, like could be even out of state. So again, there's still good retention rate, but more work needs to be done in this direction. We have relatively limited staff when it comes to our survivorship program. One physician, myself, nurse coordinator Mary, and we have clinic nurses helping us when we provide visits within our clinics, and actually radiation oncology department provides this clinic space and subsidizes my time and Mary's time to a degree, because this is not typical radiation oncology clinic, one can imagine. We also utilize our social worker within the clinic, and again, I have to really thank my department for providing these resources and being really generous with it. My commitment to this clinic is kind of part-time. I have other commitments. I treat lots of newly diagnosed kids and some adults too, and again, this is not an easy balance, but we've definitely are committed, because this is very important to all of us. So this is Mary and I's program co-leaders, and our contact information on Winship website. I do want to mention and take this opportunity to thank some of the support we received. I've mentioned the initial Emory Children's Research Seed Grant, and then since 2008, we've been very fortunate for a number of years. I want to say maybe close to 5 years, we've been receiving grant from Raleigh Foundation, which is a local philanthropic foundation for childhood cancer survivors, which then become like really national player when it comes to this supporting research, and they've recognized and again importance of survivorship issues, and helped us with research, funding research portion, which resulted in some good reports and publications we produced, but also supporting survivors themselves, underinsured survivors, with actual reimbursing their visits and things, which was very unique and very difficult, when you think about like how we can bridge this, needs when people are underinsured and they need this surveillance tests and visits. And as I mentioned, also grateful for our department for subsidizing our effort in our space. We also are very pleased, just literally 2 weeks ago, we received the announcement that we will be awarded this NIH P30 funding, which is administrative support for projects. This is research project we'll be funding it with, but it has really important aims, like what we are basically describing, some of this transition of care and some challenges with it, and understanding these challenges and addressing that. And this will be definitely mostly focusing on our population, which is like state wide, obviously, which serve entire state of Georgia, and We have also a very diverse population, luckily compared to many other states. We can look into some of the unique, needs and barriers. And again, we have mostly metropolitan, population, but about at least third or so we have rural population that comes to us for service. Again, will be great research and hopefully will produce some interesting findings. So at this point, I'll hand it over to Mary to continue the next part of this presentation and inform you about practical steps, what happens in our clinic. Thank you, Mary.
Thank you. Okay. All right. You can go to the next slide, Nadia. Is that my slide? Is there one before that?
Yeah, that was yours too.
Okay. Go to the next slide.
Okay.
Go to the next slide. I thought there was a slide before that. Okay. I feel like I'm missing a slide, but anyway, again, my name is Mary. So the slides might be out of order of what I was thinking in my head, but I will start with on how we firstly get the referrals from Children's Healthcare of Atlanta or outside referrals. And there is a transition clinic that they have 6 times a year at CHOA. And I didn't used to go to that in the beginning, but a lot of what we do now has evolved from over the years of what might work and what does work best. So firstly, I do go to 6 transition clinics at CHOA, and those are the clinics where the patient is turning 20 or has turned 21, and that's their very last visit for survivor clinic there. And so they kind of wrap everything up in a bow for the patients. And it was thought that it would be a good idea for me to go meet them at those clinics so they can put a face with a name, since they're going to be leaving the care that they've been used to for so many years. So I do go to that clinic 6 times a year. They typically see for transition patients that day, maybe 4 to 6 patients. So that's, about 25 patients a year. And then they also see patients for their last visit other times throughout the year. So that's where we get the number of like 80 transition patients a year that are transferred over or referred to Emory. So next slide, Nadia. And so one of the things that they do try to start preparing the teenagers for when they are aged out is a program called 21 Steps to 21. And basically it's just around the age of 14 to 15 that they want them to get used to taking care and taking ownership of their care. So when they're a young adult, they can be more independent. And this, of course, goes at a different pace for each patient, depending on their current health status. Parents have always been used to taking care of everything. Sometimes they don't want to let go of things. But basically, in the beginning, they just want to make sure patients in their teens can say what their cancer diagnosis is. What are some of my late effects? Where can I find my survivorship healthcare plan? And we'll talk about that in a minute. What's my insurance? How to make a copay, how to call and get an appointment started. So a lot of these are basic steps that they start introducing to them. Next slide. So that by the time they are 20 or 21 and have come to us, they have an idea about what all goes into making an appointment rather than their parent calling and doing it for them. Okay, next slide. So, okay, this is what I was thinking of. So yes, I do go over and meet with at the transition clinic. So on that day, when I go into the room to meet them, some of them I may already know because they may have had radiation before. So I will introduce myself, tell them that I will receive their survivorship summary in a couple of weeks. I'll review it. If they're already a patient at Emory, I'll get it scanned into their chart here. And then we can kind of briefly discuss if they're going to need adult specialists when they get to Emory or wherever they do choose their specialty. And I can help make sure the records are scanned in. So for the, when they call to make those appointments, they have the records, and just sort of be a liaison, not only for Dr. Nadia's clinic, but for the other specialists that they may need. And then they also receive a notebook at that visit, and it's got their SHIP in it, plus other important phone numbers and resources that we're going to have when they transition to adult care. Next slide. Most of our patients that we see in our survivor clinic and at CHOA are from the Georgia area, because naturally they were probably treated at CHOA. So they go there for their follow-up care. So patients can be, either from the Atlanta area or North Georgia, South Georgia, 3 hours away, 4 hours away. Some of them live right in Atlanta. We do have a few patients that will come from out of state. Close states nearby because they want to maintain the continuity of care. And also a lot of them just like having all their doctors at Emory, just so it's a little bit more cohesive. And then of course, sometimes people move to Georgia from out of state, and they look up, sometimes they do a search, they find out about Survivor Clinic at Emory. I'll get a call from them, and this seems to have been a rush of these lately, but I've gotten a few calls in the past few weeks for young adults who are here in Atlanta doing their graduate school. So they might be at Georgia Tech or Emory, and they want to come to our clinic, or they've come here for a new job or relocated. So I get referrals that way as well. Next slide. And then on the reverse side, sometimes the patients that we're used to seeing here move to another state, and they want to know how to set up survivorship care when they move. And so there is on the COG website a database for finding clinics in other states, and it's really easy. I just go and do a drop down for the state they're moving to in the city, and then we can click on the actual center, and then I can see if they still see patients over 21 and for how long, and get contact information. So it does work both ways, and that list has come in handy for finding survivor clinics when patients move to other states. Sometimes when it's not convenient for them to go to a survivor clinic, be it come to Emory or out elsewhere, we can ask them to have their primary care doctor do the screening test. And as long as the primary care doctor has their SHIP and the patient's history, they can probably order most of the test. Some people may ask why our survivor patients don't stay with their oncologist to do late effect screening, but typically the oncologists see their patients, for up to 5 years or so for their regular screening, for their scans and everything. But as they age, as they get further out from treatment, they're not seeing those patients on a regular basis. So that's where survivor clinic comes hand in hand. And also patients can see their primary oncologist and survivor clinic at the same, in the same year. And they certainly do at CHOA when they're still less than 5 years off of therapy. And sometimes we will get referrals for us, and the patient is not quite 2 years off of therapy. And oftentimes they'll also need medical oncology or hematology care while they're doing survivorship clinics. So it's not always, black or white there. Next slide. So as far as the number of patients that we see every year, I started keeping a tally of it when I was doing this role. And then I really started getting more detailed with how many patients we see a month and a year. So as you can tell, it has increased from when I started doing this a lot more in 2014. So now I would say Dr. Nadia sees over 200 patients a year, and that may not capture everybody because some people come back for an interval visit. And obviously in 2020, there was a big dip due to COVID for about 3 or 4 months, and now we're back scheduling everybody. So right now we've seen almost 150 patients, and we haven't even, started, we haven't hit the end of the year yet. So it's always growing because there's always somebody turning 21 and getting referred. Next slide. So the word SHIP is something I started to hear about a lot when I started doing this role, and I didn't know what it was. I thought that was, I just didn't really have an idea. So as I had to start learning what a SHIP was, it's basically a very useful tool for populating a patient's treatments, and then it populates the late effects to screen for. And this is generated at CHOA. They have it in their Epic system. We don't have it at Emory. So I will often get emails from them. Hey, can you send a radiation summary on so-and-so? And then they start putting all the treatments together, starting from the date of diagnosis, any surgery, chemotherapy, and radiation. So this first page you're looking at is kind of just a quick glance of their diagnosis and the screening. And then you can go to the next slide. And I chose to do one for brain tumors and CNS patients only because their treatments are a lot more complex, or late effects are a lot more complex. So I thought this would capture the most complex patient, but not all of them have this much late effects to screen for. So anyway, the second page, I usually start with the date of surgeries and the chemotherapies. Next slide. And then the radiation. So they like to have exact doses and start dates, because that's when they put that into the template, that's kind of what tells us and them the exact screening to the exact things to screen for. So keep going, Nadia. And these SHIPs can be about 10 to 15 pages. They look a little daunting at first. A lot of things that I'm looking at, because I've gotten used to seeing these, a lot of the late effects initially can be screened with blood work, doing a CBC, comprehensive panel, checking for counts and electrolytes. And then as you get into like the cranial and spinal radiation, of course, they need to have their thyroid levels checked. Most of them are seeing a endocrinologist by now. Sorry, I'm getting a phone call. Next screen. So again, just more late effects to be screening for. You can go to the next more. So again, like I said, these ships can be about 10 to 15 pages. Next screen. So with cardiology monitoring, this is one of the common toxicities that we do screen for. And this information is from the COG website that Dr. Nadia mentioned and did get updated in the past few years, because I will tell you, there were patients we were doing echoes on every year. So they decided that, based on the dose of anthracycline and whether they received radiation or not, or both, or just one, the monitoring went down somewhat. So I go by this for screening for the echocardiograms. And then if someone already needs an echo every 2 years, that tells me they got a substantial dose of anthracycline and or radiation, I will go ahead and try to refer them to Dr. Parashar or Dr. Mandawat. Dr. Parashar has been seeing our survivor patients. She took a keen interest in them about the time Dr. Nadia's clinic started. So we definitely refer a lot of patients to her. Dr. Mandawat, I believe, sees more patients who were treated as adults, but that they are part of the cardio-oncology service, and Dr. Mandawat is the director of that. Next slide. Another common thing that we screen for women is breast cancer, especially if they've had chest radiation or sternal radiation or thyroid radiation. So typically they would need a mammogram or an MRI starting 8 years after treatment or at age 25. Usually for us, that starts at age 25 by the time they get to us. So that's part of the test that we order for them when they do their visit here. Next screen. Colon cancer screening is another common thing that is screened for, especially for the patients who receive radiation to the spine or abdominal area. So we already have this on our radar that at age 30, we're going to refer them to the GI team. And of course, if something changes sooner, we make that referral sooner, but we refer them to the GI team here or an outside GI doctor if they prefer, and let them decide if a colonoscopy is indicated or the stool DNA test. And usually the colonoscopy is what they do. So we let them take that from there. Next screen. And then other referrals that survivor patients need or are told to already have, before they age out of CHOA is a primary care doctor. That's kind of one of the first things I mention to patients is, do you have a primary care doctor? Because sometimes they like to confuse us with primary care, but I have to tell them, we're not primary care. We're not going to treat, colds or sinus infections or anything like that. So I do try to make sure when I do my initial call that they have a primary care doctor, and I can give them the health line number at Emory. Sometimes they like to get a primary care that's with Emory, so everybody can see everybody's records. Endocrinology is one of the big services that many of our patients need for managing thyroid function or endocrinopathies, just to kind of even to watch for baseline problems. So that's a common referral that we make, as well as gynecology for females for well checks, or especially if they've had pelvic radiation. Next screen. Fertility specialists come into play a lot because when people are in their 20s is when they may start thinking about a family more so than when they were a teenager. Sometimes the males were able to do sperm banking before they came to us. Oftentimes we don't see too many times where the females have done egg harvesting. So by the time they come to see Dr. Nadia and us, they might be ready to have that talk. And I kind of call it a fertility talk if they want to initially go and see the fertility specialist. And then we do have females who do start doing egg freezing even before they're married, so that they can do that now while they're more able to. So that's a big referral that we place. Urology, of course, sometimes people come to us with urostomies or bladder issues, ED issues. So we refer them to neurology. To urology, sorry. And then neurology and neurosurgery, of course, if they're on anti-seizure medicines. Sometimes our patients just have chronic headaches and migraines, or have shunts, cognitive impairments, or if they ever needed additional surgery, then we've got them plugged in with the right specialist. Next slide. So for the nitty gritty, when I'm scheduling a patient, especially for their first survivor visit, I kind of call it like the initial intake for that first time phone call for the year. It can kind of be the longer call because they're not really, especially if they're not part of Emory yet. So we get their demographic, their insurance. I always like to check to see if it's in network for Emory. And then I review with them their SHIP to kind of say, these are the tests that we're going to schedule. And do you have any other health concerns that we need to address? And then we discuss a day that they can come in to see Dr. Nadia and what tests we're going to need that day. So I do have to plan it far enough out to try to get the tests we need that day and see Nadia on the same day, when we can try to sync up all the visits at one time. In some cases, it makes better sense to do the testing first and then see Dr. Nadia. I especially like to do that if we're going to have MRIs and CT scans, but it doesn't always have to happen that way. It kind of can depend on patient preference, scheduling availability, insurance approval. And then, of course, there's some patients that prefer to do their tests locally and have the results sent to us and then come here for an office visit, or we can set up a telemedicine if they live in the state of Georgia. We didn't do a whole lot of telemedicines until COVID, so that's kind of become a little bit of a new norm for some people. And of course, we can only do it if they live in the state of Georgia, but that has become something that's a little more common now for some patients. Next slide. So also when I'm talking to patients, if they don't have insurance, we need to discuss how they can get their follow-up done. I'll often make a referral to our social worker or our financial counselor. I'll send them links to low cost or free medical care in their county. Sometimes that works, sometimes it doesn't, but mainly we try to get them talking to our financial counselor and just try to find some way to obtain insurance, whether, sometimes these patients are not able to work, they cannot afford anything from the exchange. So we have to get creative sometime for how they can get insurance. Charity care is something that is done on a case-by-case basis for our patients. It has to go through screening with Dr. Nadia, our department head, our financial screening. But then again, not all of the departments at Emory take charity care, but sometimes it is good enough for me to get lab work done, echoes of their heart. And then it has to be renewed every year as well. And then if a patient lives in Fulton or DeKalb County and they don't have insurance, they can consider going to the Grady healthcare system and, doing care within that system. And I always encourage them to have some sort of insurance when possible. And then again, if they can't come to Emory, then hopefully their primary care can help screen for late effects. Okay, so scheduling, once I'm through, getting all the tests set up and scheduled, this is a template that I made for myself, so I wouldn't have to recreate the wheel every time I send a schedule to a patient. And this is a lot of tests. And believe me, there have been patients who have done all of this sometimes in 1 or over 2 days, but this isn't typical for every patient, thank goodness, but it does help me just sort of be able to delete what I don't need and then put everything and plug in the dates and times for what they do need. So ideally, in my perfect world, I like for patients to do labs in the morning, do their testing, and then see Nadia after lunch. That way the labs are back. Sometimes the imaging results are back, not always, but at least it gives it time for some of the results to get back. But again, sometimes we have to go within what works for scheduling for the patient and for the clinic. I can't always get everything, back to back, but I can try. And then, so after they come to see Dr. Nadia, I give it a few days for their test results to all come back final. And then I will call the patients, we'll go over the test results, discuss any abnormal results, and if referrals are needed to be made at that time. And then I always say, I'll call you in 1 year, but if something comes up, you're always welcome to call me. And patients certainly do call me throughout the year for things other than their 1 year visit. And one of the common things can be something that's scary for any patient, but for cancer survivors especially, is if they start to feel new or enlarging lymph nodes or masses or having any kind of related symptoms to when they were diagnosed, that can be a big scare. So when I get that call, I usually get with Dr. Nadia to, say, do we want to, have you see them sooner, or do a scan, or have them go see primary care and then come see us. And then I have a lot of patients who might call who are in college or working, and all of a sudden say, golly, my memory is so bad lately, I have a hard time paying attention. And so for those patients, we might refer them for neurocognitive testing or neuropsychiatry. So this slide is just the various resources that we have at Emory for cancer survivors, not just the young adult cancer survivors, but adult cancer survivors in general. And then these are just resources for survivor patients. And these are links I have accumulated over the years. Sometimes I learn from my patients about resources, or I find something on my own. But so some of these patients have applied for, are the slides moving, Nadia?
No, I moved them to
Oh,
shoulder.
oh, okay. I'm sorry.
Sources
And
now.
so a lot of these resources are just sometimes patients can get help with fertility testing, fertility, um, uh, what they need for egg harvesting, or sometimes a scholarship for college. So I will send patients here if needed. There's a young adult cancer survivor group on Facebook. It's more of a social network. They don't do anything like, they try to have fun. So patients can belong to that. And then there's also Winship at the Y. Live Strong. I think I helped someone. I sent someone a referral. Someone asked about help with fertility testing, and they have a program where you can apply for that.
We are approaching time, Mary, but
I think this is the last slide for Mary, and I'll just have very few closing comments, I guess, and some things I want to kind of use the opportunity to make some future directions and needs call for. And we definitely need to increase access. We have still unmet needs, and like we've heard, survivors numbers are only going to grow, and we do need to think about additional clinics and resources within the state of Georgia. We also need to, within each system, have more services, access, improved access to different things listed here: psychosocial support, rehab, physical therapy needs. But most importantly, I think I see like great need to expand coverage. We still have underinsured survivors like borderline physical disabilities cannot get Medicaid coverage. Even with Medicaid, they cannot get services they really need. So we definitely need to advocate for these people, make strong, again, call for the services and, help them to get the care they need and deserve. Thank you for the opportunity, and I think we're now ready for questions.
Yes, thank you all so much. And Georgia Core will actually be starting some advocacy efforts up. So we'll be sharing that information as it comes up. But thank you all so much for your time today. We do have a few questions, so I'll go ahead and ask those for the audience. The first question is, how do you counsel AYA patients on their future fertility impacts that they might have had from treatment?
Maybe I can take this question. These survivors, many times they would already have some knowledge of these fertility risks from childhood cancer, like treatment phase. They all get, counseled and consented for it. Depends on their age. Some may not remember anything from it, and only caregiver parents knows about it. But by the time they come to us, they already have received some initial counseling at AFLAC, because they actually are age appropriate to start addressing this. But actual step to take forward, like Mary pointed out, happens in our clinic. So every visit, people who have risk, and as you have seen, they're actually put into their health plan, and these risks they already have known about. We still have to revisit. It's just a matter of educating them about this risk ongoing or accumulating in young women. Unfortunately, this only increases with aging. So again, every visit when patients have such risk, we dedicate time to address, educate, and offer referral to fertility program. And it's obviously very personal, very delicate subject, and people make very personal decisions about it. And but something very important, we can't miss the opportunity if they're eligible to have any harvest and fertility preservation options.
The next question is, do you see patient navigation emerging as a way to address barriers for this patient population?
Mary, do you want to take that?
Okay.
I can tell from my perspective, I can say at least a few words that I cannot even say enough about like Mary's role, and I can not even function. Like this program cannot exist without nurse navigator like Mary, because she makes it all possible. As you saw, this work that goes in the background to even schedule these visits and schedule tests and everything that we need to have, like hours of work that goes on the front end before patients even make to clinic is again, without it, it's not possible even to think about this care model. Besides, it's very clear, supported. Actually, I didn't get a chance to show. Research shows that nurse navigators are pivotal, like in adherence to this care, because many people would just like have major attrition without it. This hands-on and this very again personable care what Mary provides to our survivors and families is invaluable. And lastly, survivors themselves and caregivers. I can't even, list the compliments, we're receiving about Mary's role from she's from, godsend, and, she's like amazing. And I just can't even list everything, but we hear every single survivor, has to comment on Mary's. And appreciate it.
Well, thank you. I will say it probably helps patients to have a point of contact, which is, I guess, me, because Emory has such a complex web of care. Sometimes we're spread out over 20 miles of Atlanta. Sometimes, patients go one place for an MRI, they go another place for echo, they come see Nadia. Certain clinics are now in different locations. And so even this morning, I had a patient call me to just please send a message to some of her providers at Emory, because it's just hard to grab everybody at one time. So I think for me, for them, having a point of contact, sometimes I tell them I don't want to jump in and do too much. That might be confusing if several people are asking, the same question, but I think it does help to have someone who knows the Emory system to help navigate for patients. And I do tell patients it is better for them to get on the portal and they can direct message their providers. And that's a good way to ask questions and everything. But I do think it just helps to have a good one-person point of contact. They can usually reach me directly rather than calling a call center. So that helps. So I would say that's been, a good benefit for patients.
Okay. All right, next question is, and hopefully I say this word right, that's coming up. But the question is, have you seen any data or evidence about the alkylating agent chemotherapy associated with increased risk for colorectal adenomas in childhood cancer survivors, possibly requiring earlier colon cancer screening? And I'll put the question in the chat as well, just in case you need to see it.
Yeah, I'll answer this question. Obviously, I know we watch all the evidence that's coming out, and I'm actually on several. I've been on several task groups, like late effect specific or treatment specific, and now I'm actually in expert group. Like there are 2-3 radiation oncologists nationally who are monitoring this evidence, and when it comes out, if it's strong enough to change guidelines for screening. We have not seen actual strong enough evidence, at least, or data that would support such screening. At this point, it's only required for radiation as a risk of second cancer or colorectal cancer risk, or I know adenoma sometimes are precancerous, but again, I don't know of such risk yet.
And I will just add to that, Dr. Nadi, this is kind of things always come in pairs, but I've had a couple of calls from a patient and a dermatologist in the past few weeks where they've seen some of our brain tumor patients, and they're noticing that they have an increased number of basal cell skin cancers. And then also on their colonoscopies, they've got lots of adenomas. And so looking at their diagnosis, which might be medulloblastoma, they're piecing together, could these patients have Gorlin syndrome, which is a genetic issue. So that's something else just to look at. Sometimes when patients see different providers spread out through the years, you don't connect the dots. And then finally, when the dots do get connected, there may be an underlying genetic issue going on. So of course,
that's a great point, Mary. We pick up quite a few genetic predisposition,
yes,
predisposition syndromes, and we have actually referrals to genetics team for that.
All right, awesome. Well, those are all of the questions. And again, I would love to say thank you to you all for sharing your information with us. For the audience, we will be sharing the recording of this after it's been processed. We'll get that shared with you. We'll also be sharing a survey with you. So if you could take your time to complete that, we use all of the results in the surveys to create more programs for CPNG. So your feedback is very, very valuable. And then lastly, we'll share all of the resources that Mary shared today. I know that she had some links in her presentation, so we'll get those shared with you so that you can quickly click on those whenever you need to use those for yourself. Once again, thank you. It's been a pleasure, and I hope that everyone enjoyed the webinar today.
thank you.
Thank you.
Bye.